A very good morning, everyone, and thank you to the IBank Association of India as well as to APAO for inviting me to give this talk on the evolution of IBank in the age of selective lamellar keratoplasty. I'm ANSHU and I'm the Clinical Director of the Singapore IBank in Singapore. Um, so the blindness due to corneal disease, we know it's the sixth leading cause of vision impairment globally, and over 12 million people the world over need corneal transplants. But only 1 in 70 eventually get a cornea. So these are staggering figures, and of course this is from data taken in JAMA in 2016. And so if you look at Singapore itself, the top indications for corneal grafts in Singapore for us would be PBK, failed grafts, Fuchs endothelial dystrophy, so on and so forth, which might be slightly different from other Asian countries around Singapore. And again, we do surgeries for optical, therapeutic, and tectonic indications. And typically for us, with the advent of lamellar surgery, a lot of our optical grafts are today only lamellar. We hardly do penetrating grafts for optical indications. So this targeted replacement of diseased corneal layers was indeed a paradigm shift, because this was aimed at only treating diseased cornea, and this has led to significant improvement in corneal graft survival in the long term. So we've had anterior lamellar keratoplasty techniques, we've had posterior lamellar keratoplasty techniques like DSEC and DIMEC, and DSEC and DIMEC has really changed the way we do corneal surgeries today. DOLC has been challenging, the learning curve has been steep, so the take-up rate has not been that high. But with these change in mindset and the way we do surgeries today, the IBanks around the world have had to also adapt. And this has posed a significant challenge to the IBanks, and they have actually been very good at making sure that they provide us with excellent quality corneas that are necessary to improve vision. So the IBanks have expanded their capabilities in order to meet the needs of the surgeon as well as that of the patient, because each type of lamellar graft has its own unique tissue requirements, and donor acceptance criteria and parameters have also had to become more specific. So there was initial hesitancy by the surgeons to take on pre-cut tissue, but when there were a lot more published data to show how it was good, not just for the patient, but also for the surgeon in terms of reduced operating time, taking the whole burden of having a complication during surgery when you're doing a corneal tissue preparation, led to an improvement and enhancement of the care that we offer to our patients. And open container processing performed by IBanks for DSEC and DIMEC has now gained widespread acceptance. There have been some reports of microbial, specifically fungal contamination in the IBanks that are processed for EK specifically. But again, there have been changes that, especially in Singapore, I will be sharing with you in a short while, what we have done to reduce that incidence, and we don't have any fungal contamination in our processing in Singapore. So the IBanks are now looked upon as a value-added service to the surgeon. So I'm sure everyone knows here what the EBAA stats for corneal transplants in the US are. In the last 10 years, there has been a significant change towards doing lamellar surgeries, specifically EK surgeries, which have accounted for nearly 60% of all grafts performed in the United States, followed by PK and then ALK. So ALK still remains low compared to PK in the US. And if we specifically look at EK, in 2014, when DSEC was first started, it was the primary form of posterior lamellar surgery, and slowly and gradually, DIMEC has taken over DSEC surgery, at least in the US. And what about Singapore? In Singapore, for the last 5 years, and gradually, DIMEC has overtaken DSEC as the predominant form of lamellar surgery. And this has been because of several reasons. One is the availability of pre-stripped corneas provided by the IBank, the excellent clinical outcomes that have encouraged our surgeons to start performing DIMEC. And I'm sure the numbers will only continue to increase. So this is just a timeline of how we have evolved in SNEC since the inception of the corneal transplant program in 1991, which is predominantly penetrating grafts. And in the last 10 years, we now do more than 80% of grafts as lamellar surgery, and we hardly do PKs except for the very severe therapeutic cases that come in from our region or the neighboring countries. So what this impact has been on eye banking is that surgeons have become more stringent in their tissue requirements. I don't know how it is in other parts of Asia, but in Singapore, every surgeon has a donor-specific requirement. Some want a cell count of 2,500, some want a minimum of 2,800. So of course, we have come up with certain guidelines based on what our published data is, because everyone's worried about dislocation and primary graft failure rates. So we do have a dossier where we collect information on all corneal surgeons in Singapore and their tissue requirements, so that when we are in the process of distributing the corneas, we do make sure that they get what they need, because we do not want cancellation of surgery or wasting of the cornea. There are also new donor evaluation criteria, donor exclusion criteria, because now, especially with DMEC, we can use corneas that have scars, large arcuses, which have pterygium, and even previous LASIK surgery. And of course, donor age requirements have also evolved between DSEC and DMEC. With DMEC, of course, we try not to use younger tissue, as we all know, because of the difficulty in stripping the DMEC tissue. Other issues would be diabetes and jaundice. Initially, when we started the DMEC processing program in Singapore, we were not taking corneas from donors who were diabetic. But recently, we have started selectively, based on a grading scale that has been provided by US, we have started doing some cases, and we've done, I think, 4 or 6 corneas now with patients who are diabetic, and we've had no issues whatsoever. More importantly, with the launch of DSEC, we have to make sure that when our tissue coordinators and our EDCs go to collect or harvest the tissue, we have to make sure that the rims at least 18 millimeter trephine is used, so that we get adequate rim for DSEC technique. What is also important is this important communication that I was telling you about between the surgeon and the eye bank, so that the patient gets the best outcome. And the Singapore Eye Bank has therefore developed their own corneal grading system, which is grade A, grade B, and grade C, depending on several criteria like tissue freshness, stromal clarity, and endothelial cell density, because then that allows us to provide the appropriate cornea to the patient who needs it. In order to make tissue offers more efficient, our eye bank maintains a dossier on individual corneal surgery parameters, so that we can allow them to give quickly the cornea that they need. This is a very busy table, but it is very comprehensive in telling us what are some of the tissue requirements for ALK, DSEC, or DMEC surgery, for example. So if you have a patient who's got ocular surface disease, as an example, you would want to have cornea that's got an intact epithelium. If you have a patient with DSEC who needs a DSEC surgery, we need to first of all make sure that we have adequate donor corneal stromal rim, and the patient is not very young, not in the, I mean, if they are young, it's still okay for DSEC compared to DMEC. And for DMEC, of course, jaundice and diabetes has been a concern, and of course, younger donors may not be that suitable. So these are some of the parameters that the eye bank professional keep in mind when they're determining which cornea goes to what kind of case. We started pre-cutting in 2011, and now today we have developed in such a way, in terms of the published data that we have, more than all of our 100% of corneas that we supply for DSEC are pre-cut by the eye bank in the Singapore Eye Bank. And as I mentioned again, it is very, very important that when we recover corneas, we have to ensure adequate rim size of 18 millimeters using an 18 millimeter scleral trephine. This is the typical pre-cutting setup we have in the Singapore Eye Bank. We use the Moria Evolution 3 ALTK unit with an ISO class 7 clean room. There's an operator who is the TC who does the procedure and pre-cutting, and a circulator who helps this operator. We essentially have an ultrasound pachymeter, an infusion sleeve with IV bags, so that allows us to do very, very precise cutting. So since we started pre-cutting our tissues for DSEC in 2011, we have so far done over 2,000 procedures, of which our success rate has been 98%. And 94% of these cases have been released for a successful corneal transplant. The mean posterior lenticle thickness has been about 100 microns. And between pre-cut and post-cut endothelial cell count, the average cell loss has been less than 1.2%. And internally, if we have cell loss of greater than or equal to 4%, we do not offer that tissue to the surgeon. We very meticulously record all the pre-cutting data and analyze it to refine our algorithms further. Every month, we do an environmental monitoring of the lab, and we report any bacterial or fungal infection in recipients. And so far, we've had none. So what's the advantage of having an iBank prepared tissue versus a surgeon cut tissue, which I'm sure every one of you know here? The biggest advantage for the surgeon is that the stress is reduced, the operating time is reduced, and of course there is enough data to show that surgical outcomes are superior, if not better. But from an iBank perspective, I think the most important thing that pre-cut tissue allows us to do is that it allows for quality assurance even after processing, because we make it mandatory to have a slit lamp exam and specular microscopy after we've cut our tissue. So this is how we do quality assurance for our pre-cut corneas. We do a mandated slit lamp exam, a specular exam, both before and after processing. We have an AIOS2025 machine that helps to determine the exact posterior lenticle thickness and cut profile. And this has now made it very easy for the surgeon to determine and tell us that, okay, I need a less than 100 micron cornea, then we will try our best to see how we can accommodate that. This quality assurance is important because it allows the iBank to meet the standards of quality and safety and provides confidence to our end users, the surgeons, that our tissue conform to expected international standards. Going on to DMEC, again, we started a slow start because we were a bit cautious about how the long-term outcomes were, and there were reports of how there were greater risks of iatrogenic graft failure and dislocation rates in the early days. And we were in the process of iterating our technique as well. So from 2017, in Singapore, we launched the pre-stripping DMEC donor program, and in 2018, we introduced the DMEC EndoGlide. And that has really changed the way we do DMECs, and that is why the number of DMEC cases have gone up. So this is just to give, again, a timeline between November to December 2017 to April 2019, where today we are providing pre-stripped donor tissue to more than 99% of corneal surgeons in Singapore. What is also important for all iBanks and not just within Singapore is that we continue to learn, because techniques will evolve, newer techniques will come on board, as some of the other speakers have said earlier, that there is constant evolution. So we continue to see how we can improve our techniques by getting experts in the field from the US to teach us and give us tips. And this is basically a concept of train the trainer program, where we learn and then we pass on that knowledge to our juniors, so that we can make sure that the results are consistent and reproducible. This is what our typical iBank form is for pre-cutting. There's a diagram especially for DMEC tissue so that the surgeon knows if there are any corneal tears or anything that will be of concern for the surgeon to take note of. And this is our data from the pre-stripping that we've done in the last 5 years. More than 600 procedures with a stripping success rates of 98%. And as I said, the donor age, the donors are older in our cohort, and the rebubbling rates have been much lower with 9%, and only one patient with primary graft failure in our series. What's the next step? So next step, we are moving towards preloaded DMEC tissue. We've just conducted a pilot study, and we've shown that it helps to reduce surgeon operating time without any significant risk of any intraoperative or postoperative complications. Of course, we need to do a cost-benefit analysis because this is going to be definitely a lot more expensive. The other challenge that we've had and we've come to know from the EBA Medical Advisory Board is the fungal contamination in iBank processed corneas because of the repeat warming that is needed to allow processing and post-processing assessment of corneas. What did we do at the iBank in Singapore was that we got in an incubator where the temperature was consistently maintained at 35 degrees Celsius so that it shortens the overall warming time before examination and evaluation of the cornea. We are very stringent. We track any culture results from the donor corneal rims, and these information is then passed on to the surgeon for immediate appropriate action. And fortunately, we've had no fungal infections in our recipients to date. So to summarize, The eye bank recovery and tissue processing have evolved in tandem with the shift from full thickness to lamellar keratoplasty. The surgeons and the eye banks must agree on acceptance criteria and tissue parameters for the different types of lamellar keratoplasty procedures. Pre-cut corneas for DSEC and pre-stripped corneas for DMEC have gained acceptance given the track record of safety and quality, reduced surgeon stress and operating time, and overall convenience. And the eye banks the world over, not just in Singapore, have proactively taken steps to address and mitigate the occurrence of fungal contamination in eye banks, especially for EK corneas. As newer and better forms of corneal transplantation evolve, the eye banks will always be there to provide support to all our surgeons. So this is the, thank you. This is the fantastic team that I have in the eye bank in Singapore.
We'll call
that works
next
tirelessly.
Yulia, Dr. Yulia.
We are short in time.
Ah,